Next, we have Jordan Roberts, Director of Government Affairs at the John Locke Foundation, and he is going to discuss granting nurses full practice authority benefits for North Carolina. Welcome.
Thank you, Madam Chair, co-chairs, members of the committee. Thank you all so much for the opportunity to come here and present to you all this morning. My name is Jordan Roberts. I'm the Director of Government Affairs for the John Locke Foundation, and prior to this role, I spent 2.5 years as a healthcare policy analyst at the John Locke Foundation, writing, researching about all things North Carolina healthcare policy related. And yes, I'm here today to present on what we see as the benefits for North Carolina of granting nurses full practice authority. So first, I wanted to start and sort of just frame my presentation in terms of some of the problems that I see with healthcare, healthcare access. And something that I often find is that I think when we talk about healthcare access, there's two different ways we can talk about that. We can either talk about raw numbers of people who are covered by health insurance, or we can talk about actually having readily available access and ability to receive medical care. Like Senator Corbin said, if you are in his district and you have an insurance card, you're covered, but you can't actually access any readily needed medical care. So I think that we need to be specific, and I would argue that we should focus on the latter instead of the former. Two, I think we need to re-examine the delivery of healthcare. I think we have a system full of really good providers, but it's a system that has really bad incentives, including the payment incentives, and oftentimes that stacks the deck against the patient and pits industry players against each other, sort of all, again, working against what should be the goal of this, which is good health outcomes at the most affordable cost. Next, the Affordable Care Act and the growth of North Carolina's Medicaid program. This increases the demand for healthcare services, and it's my opinion that we really haven't done anything to increase the supply. And just on a basic economic level, we know that when demand for services increase and supply doesn't meet that, prices go up and there's problems with access. Next, as we've heard a lot throughout these different presentations, we know the problems with shortages, but especially with North Carolina's geography, we suffer from a maldistribution of providers too, so just something to keep in mind. And then lastly, which I'll talk about a little bit more in my presentation, but there are declining numbers of primary care physicians entering the workforce. And when we talk about healthcare access in the state, you'll notice I'll focus a lot on primary care. So this is something just to keep in mind as we look towards healthcare reform in the future. So what I believe we need to do is fully deploy our healthcare infrastructure and our healthcare resources that we have in this state. And current laws, we've heard, limits APRNs from practicing at the top of their license at the fullest extent of their training. And like we've also been talking about, these reforms in the SAVE Act, these will allow nurses to practice freely and at the top of their license. And I want to draw this chart is from an article that was published in 2018 in the New England Journal of Medicine, and I want to draw your attention to the column on the far right. This is the projected average annual growth rate of 3 different professions: physicians, nurse practitioners, and physician's assistants. And as you can see, nurse practitioners and physician's assistants are projected to grow much faster in the coming years. And so if we think about how to reform our healthcare system and how our state can adapt to meet the needs of what our citizens need, we see that the projections show that nurse practitioners and other advanced practice registered nurses have similar projected growth rates. And so we know what the problems are. We know how the market or the workforce is going to adapt. So again, something to keep in mind as we're talking about the reforms in this proposed legislation. And what I would like you all to think about this bill in terms of a regulatory reform issue. Oftentimes, members of this body, members of the public will come before you and say, we have a problem with the regulation, it's raising costs, it's limiting my ability to practice, and that's a lot of time what this body looks at, and that's what we have here. We have a regulatory reform issue that limits access to critical services. It raises costs, like we'll talk about in a minute here, and it limits the ability of highly trained professionals to practice at the top of their license. So this checks all the boxes of a regulatory reform issue, and I think it gets bogged down with a lot of the passion around this issue, but at its core, that's what it is. And I won't go, we've touched on these two charts here, but I think the main thing I want to make a point of here is that legislators often like to see how we compare to other states, and it's my opinion that with all of the APRNs, we're falling behind other states that have realized this need and accepted that they need to make changes to adapt to their coming workforce challenges. So these are not new or novel ideas. States have made it work, and like we've seen, there's no significant stories of any bad health outcomes or anything like that. So I really wanted to focus part of my presentation on the cost and tax benefits associated with full practice authority. And I wanted to highlight, which I'm sure a lot of you are familiar with, but a study done by Dr. Chris Conover in 2015. And the bottom line finding of this was that granting full practice authority will lower healthcare expenditures and create higher tax revenues for North Carolina. And the way that he does this, and which I think is a very robust model, he builds an economic model that builds in all these variables about projected consumption of healthcare, the costs associated with where we get that healthcare, and I have no reason to doubt anything in that model. And so remember, this study's a few years old, so these findings are in 2014 dollars, but what Dr. Conover finds is a annual health cost savings, so this is a reduction in health expenditures associated with full practice authority, a lower end estimate of $433 million to an upper end estimate of $4.3 billion. And again, these are raw reductions in health expenditures in our economy. And then two, the other part of this is that with more with APRN's ability to participate more in the economy and in their own businesses, we have an increase of tax revenue too. So just an added bonus onto this reform is that we can actually increase economic activity and collect more taxes in the state, and that's on personal taxes and taxes on production and imports of their practices. So where do these cost reductions come from? Training costs are lower. So from an economic standpoint, we have scarce resources to get professionals in the field, namely time and money. And what we know from the research is that these professionals cost less to train, to get out in the field, to deploy, like we've heard, a lot of the same services. Next, compensation and reimbursement levels are lower. In a lot of cases, physicians and APRNs are providing the same services, but physicians are paid at a higher rate. As we talked about, this supervision adds a layer of administrative costs and administrative bloat onto the practice. And with this idea of supervision, a lot of times there can be claims from multiple providers, again, adding on to this administrative bloat and unnecessary costs in the system. And then two, from an economic perspective, if we increase the pool of providers, we can help put downward pressure on reimbursement negotiations, just having more providers available to help with covered lives. Next, this is something that has been talked about today, the use of medical care resources. What we find in the data is that most of these studies show that APRNs and physicians use an equal amount of medical services, and if anything, APRNs are actually a little bit lower. And I know there's a lot of studies to dispute this. I've referenced a couple here, including a literature review of 69 studies that looked at random control trials and things like that. But I think the point to make here is that opponents of this reform often say, well, there is going to be, with the perceived relative lack of training from APRNs to physicians, that they would order more tests, they'd have to cover their bases more. Well, that's just not what we see in the data, and I think it would be more prevalent if that was the case. And then what I'll talk about more in a minute here, but I think a lot of what this bill does is helps with the focus on primary and preventative care. And we can do a lot of beneficial things for the citizens of this state by focusing more on primary care, limiting trips to the ER, and better management of chronic diseases. And that all starts with primary care in this state. So now I wanted to touch on the rural healthcare aspect of this. Members of the committee, you don't need me to tell you the problems with primary care shortages in this state. This is a map from DHHS that shows both geographic and population-based HPSA areas. And then besides just what we know, national data shows that there's a decline in Americans with access to a primary care provider. And so that's a big problem, especially if we talk about preventative and primary care. But there's also been research that's been talked about. Full Practice Authority has been found to increase nurse practitioner employment in primary care and participation in Medicaid. And so that's a good thing for all of our rural counties. And as we've talked about today, there's a big need in rural areas where nurse practitioners have been shown in research to be more likely than their physician counterparts to go out to rural areas, so this can also help. And then from the Dr. Conover study, he estimated, based on his model, an increase of 1,700 additional APRNs in the state with full practice authority. And this can go a long way to addressing almost all the shortages in the state. Now, this is not to say that this is a silver bullet for all of rural health care problems in the state, but we deny these professionals the ability to at least attempt to make a difference if we don't grant them full practice authority, and we know the need is there. And then two, I really think it's important just to emphasize this provider-patient relationship, especially in our rural areas. If we can get more people regularly seeing a provider, get them more comfortable with the healthcare system, we can save a lot of money on the back end by avoiding a lot of these chronic illnesses or just basic preventative measures that we can address up front. Next, I wanted to talk about direct primary care briefly. For those of you who are not familiar, direct primary care operates like a gym membership. You pay a monthly premium or a monthly membership fee to the provider, and industry data puts this for your average adult at about $82. You get around-the-clock access to primary care, and the reason that these practices are able to keep costs so low is they don't deal with insurance. There's no third-party reimbursement. It's just you paying for medical services. And the legislators passed HB 471 not too long ago, which protects direct primary care practices from being subject to insurance regulations. So we have a very strong law that protects these practices. And if we were to grant nurse practitioners full practice authority, here's another low-cost way that nurse practitioners can serve North Carolina patients in a primary care setting. And this is sort of a niche market right now, but it's growing. As you can see, in 2014, there's 125 practices, and we're up to 1,500 across the country, and we're up to 76 here in North Carolina. And then also, there's been bipartisan federal proposed legislation that would allow DPC membership fees to be an eligible HSA expense. That has not happened yet, but I believe it will, and once that is, more Americans will have more options to pay for direct primary care. Two more points I wanted to leave you all with. The first, another part of this that we can think of in benefiting the economy is how this reform would benefit employers, especially for the 76% of employers that offer self-insured plans where they're bearing all the risk, paying claims out of pocket. If we have artificially inflated healthcare prices, as like we've talked about, by limiting APRNs, well, that's money that businesses in North Carolina are paying that they wouldn't otherwise have to, and that leaves less money for wages and other benefits. So I think you can think of this too as a sort of a business reform, and we know how expensive family and individual premiums are for employees. And then next, retail health clinics are growing, and especially in the South and in more rural areas, we see retail health clinics growing. And these are often staffed by either a nurse practitioner or a physician's assistant. So again, in thinking of how we can adapt our workforce to the coming needs, granting nurses full practice authority, allow them to practice more independently in these retail health clinics. And I think the best thing about these is they're conveniently located, they're low cost, and they have transparent pricing. And this is an example of the market adapting. There's deficiencies in primary care, and the market has adapted to provide it at a low-cost service for those that don't have access otherwise. And this is an area where I think regulations would stand in the way of further growth of this industry. So just briefly, in conclusion, granting nurses full practice authority will lower healthcare costs and increase access around the state. I know we've talked a little about a few studies presented today, but in the course of my research and what I've seen, I haven't seen any evidence that shows allowing for full practice authority leads to overall negative health outcomes in a state. These supervision requirements threaten the ability of APRNs to practice, and what I mean by that is, and I think this was mentioned in an earlier presentation, but imagine if your profession was at the mercy of someone else that you have no control over, and at any time they could decide to pack up and leave, and you don't find another supervising physician. Again, that's care that we're directly taking away because of these supervision requirements. The reform could alleviate shortages and attract people in our state. I'm sure a lot of people in here, I've heard from people that would like to move to North Carolina that are APRNs, but because of the practice environment, they choose not to. So that's another economic miss there. And if we think about what businesses are spending on their employees for health coverage, this reform will be good for businesses and the economy. And you're going to get this from the John Locke presenter, but there are no taxpayer costs associated with this reform, and I think that's one of the biggest things to remember as we talk about all of these reforms in this committee. So that's the end of my presentation, and I'd be happy to answer any questions.
Thank you, Jordan. Questions from the committee. Representative Baker, and we are behind schedule, so we do have to be quick.
Thank you, Madam Chair. I'm so sorry. Thank you. Thank you so much, Jordan. I appreciate your presentation, and I know we share a distinct love for data. So just a couple things. I'm trying to be brief, but in terms of outcomes, in September of 2020, the Journal of Internal Medicine showed that NPs and PAs with independent practice authority were more than 20 times more likely to overprescribe opioids than NPs or PAs in authority-restricted states. So in terms of outcome, very recent study that's concerning. Happy for you to address that. And then my other quick question is around the big study, the Hattiesburg Clinic in Mississippi. I will look up your study and compare those, but that's a model. And this study in Mississippi was an enclosed affordable care operation with 33,000 Medicare patients, and they had surprising, unexpected outcomes. 2/3 of their practitioners are non-physician practitioners, so they were fans of that model. Mm-hmm. And in having to review their costs because of their structure, like we're looking at going in our state with managed care taking over, it's a very similar model. And in looking at that, they expected that they were going to have to tell physicians to keep their costs down. In fact, it was the NPs, and it was because of the excess referrals, excess testing, and ER visits. And in fact, they found in that study that ER visits for patients who were not seen, whose primary care provider was not a physician, the ER visits were higher than for those patients who had no primary care provider at all. And this is a primary care clinic in a rural area of Mississippi. So I think it's a very similar model. So anyway, I would love to discuss that further.
I would love to. I'm not familiar with those, so once we get a chance, I'd love to talk to you about that. But I will say, for a lot of these studies, there are limitations, and I think as a researcher in this capacity, we look for trends in the data, and just the overall trends and outcomes just don't show that. So that's the reason for it being in the presentation. Representative
Cunningham.
Thank you, Madam Chair. I'm just going to make a remark. I want to thank you so much for referencing that it's reform, it's regulatory reform. And I appreciate you putting the references in your document. And lastly, we put in place within the last several years on the prescribing opioids. So we have that in place as protection. So I still think we can't go back. We need to be moving forward with regulatory reform. Thank you, Madam Chair.
Thank you, Representative Cunningham. Thank you, Jordan, so much. We appreciate the information.